Yeah, that could be good to go. Go for it.
Nice. All right. Hey, everybody. My name is Max Segars. If I haven't met you, I practice pediatric emergency medicine in the US, and I'm currently in Moshi, Tanzania. I'll be here for the academic year doing clinical research supported by my home institution, Cincinnati Children's, and a Fogarty grant. My study is called Characterizing Ambulance Care of Injured Children in Tanzania, a Mixed Methods Approach. And these are some of my mentors there at the bottom. I guess before I start, I should just say that I'm 1 month into data collection, and this is kind of a work in progress and feedback forum. So my hope is to take all the smart people in the room and have all of your input to make this a stronger project. So as far as background goes, trauma is a leading cause of mortality in LMICs, and in those systems that have a formal EMS system in place, it is the #1 cause for EMS activations in sub-Saharan Africa. Pre-hospital trauma systems improve outcomes in LMICs, but it's estimated that about 90% of sub-Saharan Africa have no access to formal EMS systems. When I say formal EMS, that is the type of system that I think about at home in the United States, where you have trained ambulance personnel who are dispatched to the scene of an injury. So if I get injured at home, I can call a number, an ambulance shows up with an EMT or some sort of trained staff who can then carry me to another hospital. So 90% of sub-Saharan Africa is estimated do not have access to such a system. Instead, much of sub-Saharan Africa has access to what is called informal EMS, sometimes it's called. And so that can take many different forms, but often, as is the case here in northern Tanzania, it focuses primarily on interfacility transport, which, just to spell that out, means that, for example, if I get injured in a road traffic accident, then I have to find a way to the first healthcare center, often by a police officer or a good Samaritan who can take me to the first healthcare center. You can then get referred up the ladder until you reach definitive care, which for our study is KCMC. So the ambulances just provide transport from one center to another and don't necessarily have integrated staff who've been trained on the ambulances. Very often you kind of take a nurse typically from the referring center, place them on the ambulance to care for the patient, and they transport them to the next setting. So in terms of ambulance trauma care in informal settings, there are really no published studies that I'm aware of for what trauma care actually looks like in these informal settings, which again cover the large majority of the population of sub-Saharan Africa. The studies that do exist apply to other populations, specifically the obstetric and neonatal populations, which have some overlap with this study, but not a ton. So the question that is motivating me is what sort of ambulance care is provided to injured children in northern Tanzania and by extension within sub-Saharan Africa. This is an image that many of you have probably seen. It shows the continuum of care for injured patients from site of injury to definitive care. This is created by the World Health Organization. And the reason that I put this up here is to show kind of the map from injury to treatment. My project is nested within a larger project called PKIDS Care, the parent study. And it has studied the areas that I'm highlighting in green here. So what happened at the injury? What was the mechanism? On the left side, you see this other hospital, the smaller referring hospital, kind of what happened there. And then ultimately on the right side, what happened in the KCMC emergency unit and in the inpatient setting. Something that is missing from this continuum of care in the parent study is what actually happens on the ambulance during transfer. So the purpose of my study is really to integrate this portion of ambulance and transport into the larger continuum of care to build a more rich, expansive picture of care of injured children. That being said, the aims, aim 1, characterize interfacility transport of injured children in northern Tanzania by establishing a prospective registry. And again, that registry is an expansion on a currently existing registry. Aim 2, describe the facilitators and barriers to timely, effective care of injured children during ambulance transport. And the overall goal is to identify gaps in ambulance care for the future development of a health systems intervention. All right, here, this is a picture that was made by ChatGPT. I created this to kind of give you a sense for what I think the final product of this might look like. So this is a mixed methods study. There will be quantitative and qualitative portions. And my hope is to kind of tell a story of the facilitators and barriers to care at initially the referring hospital, 2, during ambulance care, then 3, at the receiving facility. So don't pay too much attention to the specific text here, but this is kind of what I imagine the final product will look like, and kind of keep that in mind as I'm going through it to frame how I'm thinking about this. So in terms of the approach, this is for the quantitative part, again, the registry, which is an expansion on a current registry. I will be enrolling MEPs, which is medical escort personnel. We can think of this being like a paramedic. It's usually the nurse, a nurse typically, who is accompanying a patient from one facility to another, providing care. Inclusion criteria, any adult who transported a child, an injured child. So again, this is, in this case, we're enrolling the MEPs, this nurse on the ambulance, rather than the injured child themselves. Lots of different data sources. One, when the MEP arrives to the EMD, the emergency department at KCMC, there's a structured questionnaire that RAs will ask all of them. So just a few of the data variables regarding the MEP, their demographics, their age, their sex, etc., and then their training and experience. For example, are they a doctor, are they a nurse, something else? Regarding the ambulance, is it public, private, ALS, BLS, 2 different classifications for an ambulance, number of occupants, the resources that are available, etc. And then regarding patient care, patient monitoring, things like physical exam, which elements of the physical exam were done, which vital signs were taken, which medical interventions were done, and which injury mitigation strategies were used. By that, there are a lot of different strategies, but the primary focus on cervical spine immobilization, which could be something like a C-collar that keeps someone with a suspected injury to their neck from ranging their neck. We use C-collars often at home, but there are other mechanisms like sandbags to keep your head from moving. And then splints to immobilize like an arm if you have a fracture or something like that. And then care transition, which is after the ambulance arrives, how are they passing off that patient to the EMD? So handover and then feedback to the ambulance provider is another big portion there. Other data sources, the referral form. It's the physical piece of paper that comes with the ambulance that details what happened at the referring facility. Things like, what are the patient's injuries? What were their vital signs? What sort of evaluation and treatments were done prior to putting the patient on the ambulance, and the reason for the referral. And then lastly, the referral call book, which is where any referring facility can call ahead and say, hey, I'm sending you this patient. Here's all the necessary information about them so that you can be aware of them and prepare accordingly. And then I'm not going to go into any detail about this, but looking into expand enrollments to include adults, and then potentially at another site, Mwenzi, which is the regional hospital in this region. In terms of the quantitative outcomes, number 1, was there an appropriate patient assessment done on this injured child? There's no clear definition for what it means to have an appropriate assessment. And the definition that I think is probably most appropriate to apply is that the one that is defined by the WHO Basic Emergency Care Standards. This is the quote they provide, the ABCDE approach, which is the kind of standard that we often use to rapidly assess a patient, should be used to assess and reassess, in all caps, all patients during transportation. Vital signs, including AVPU or GCS, which is a measure of mental status, should be checked every 15 minutes, and patients should be closely monitored for response to treatment for signs of worsening. So to translate that into strictly objective variables, this is kind of my working definition for what it means to have had a WHO VEC standard assessment. So the first is that essentially your breathing and perfusion were assessed, and then two, that you had vital signs taken. Other outcomes, pain assessment. All of these patients have had an injury, so presumably the large majority of them are in some degree of pain. So it is strictly yes or no, was pain assessed? And if indicated, was pain relief provided? And then lastly, are indicated injury mitigation measures used? Again, I don't want to go into all the details here, but again, the C-collar or cervical spine immobilization, was that used in appropriate settings? And then two, were splints used in appropriate settings if I have like a broken arm? There are a lot of different predictors regarding the patient, the MEP, and the ambulance. The patient, age, sex, national health insurance, was a guardian present on the ambulance, and then some sort of quantitative measure for injury severity. Presto is one such measure that's been validated in my population that is an objective way of measuring the probability of mortality. Among the MEP, the clinical role in training, again, is it a doctor, nurse, something else, and then their perception of the injury severity. We have a Likert scale 1 to 5. It's the same that's asked of the medical team and the EMD. It goes anywhere from 1, which is essentially very low acuity injury, all the way up to extremely severe or life-threatening. And then lastly, the ambulance, private, public, BLS, ALS, etc. Statistical methods. I'm going to do some summaries and then hypothesis testing based on the outcomes and predictors above. Sample size is a bit hard to predict given that it is in the emergency setting, but I anticipate about 150 over the course of the year. The last thing, and I'll just plant a flag, this is something that I'm really curious to get people's feedback on. Probably the largest limitation of my study is that when we do these questionnaires to the MEPs upon arrival to the EMD, they could just lie. They could tell me, oh, yes, I checked this, or yes, I did that. That is possible, and there is no documentation like there are in other settings to verify the information they've provided. So one way that I'm assessing this is after the MEP provides information, we'll then ask the caregiver about the care that was provided on the ambulance. So this is the caregiver who was on the ambulance with the child. And so we'll ask 5 standard questions. One is about blood pressure, lung auscultation, which means like listening to the chest with a stethoscope, pain assessment, IV fluids, and oral medications. So as an example, the question we might ask is, while on the ambulance, did the healthcare worker check your child's blood pressure? I did create some images just in case there's any uncertainty about what it means to check a blood pressure. We have these images that we can show them. This is what we mean, and of course can describe it. The RA can describe it a little bit more if they have any misunderstanding about what it might mean. Everything has been translated to Swahili, the validity questions, the questionnaire, everything that I've talked about up to this point is available in English and Kiswahili. So there shouldn't be any language barrier. And in terms of concordance, so far everything is looking very positive. And by that, what I mean is if I ask the MEP, did you check a blood pressure? And they say yes, then I go and ask the family, did that MEP check a blood pressure? They agree 87% of the time that yes, whatever intervention was done. And the negative concordance is 89%, which is if an MEP says they did not do something, then a family will say they did not do that thing 89% of the time. Still a lot more information to come. That is the pooled concordance. I'm not actually exactly sure the best way to present this information in a rigorous way. So hoping other people have input, but just planting a flag here, and would love anybody's feedback about this. The qualitative portion, I'll go through this a little bit faster. This will start in about December, so I haven't started collecting this data yet, but planning to do semi-structured IDIs, in-depth interviews with the MEPs. A lot of different content. I won't read through all of these, but generally speaking, the decision to transport, the decision to include an MEP on the ambulance, which is not the case all the time. Pre-transport preparation, how was that MEP prepared to care for this child? During transport, what happened, what resources are available to help you make medical decisions? EMD arrival, and then kind of general logistical type questions. And perhaps plans to enroll referring physicians in the future. Nothing too exciting here. We will translate Kiswahili to English, do iterative inductive thematic analysis with deduce, use two coders, and discrepancies will be resolved by consensus. All right, so the data that I do have back, I want to just give a brief overview of kind of what the early data is showing. So as far as MEP and ambulance characteristics, about 80% of the time there is a nurse is the person who's assigned to be the MEP. There has been an MEP on 100% of the ambulances arriving to KCMC. Yeah, 80% of the time it has been a nurse. As far as the MEPs describing their own experience, there's a median, they describe a median of 30 times that they have been involved in ambulance transport in the last year. And of those 30, a median of 7 have been pediatric trauma transports. As far as the interventions that are provided, pain medications given about 60% of the time, antibiotics about 60% of the time. There are reasons that antibiotics are sometimes given in trauma. Sometimes those align with the patient's injuries, sometimes not. And then IV fluids up top about 40% of the time too. Referral calls are interesting because I definitely, from the umbrella study, the parent study, PKIDS Care, I've kind of been given the impression that referral calls are happening about 100% of the time. Now that we're actually measuring it, see very, very rarely are referral calls actually made from a referring hospital, again, to say, hey, this injured patient is coming, and here's the important information you need to know. As far as what is actually done on the ambulance, physical exam is on the left side, lung auscultation and perfusion are done less than half the time. Heart rate and blood pressure are measured well less than half the time. And then interventions, IV fluid and pain meds are given, but well below half the time as well. And again, I'm not saying that they should be giving IV fluids 100% of the time. This is kind of the pooled summary data. As far as clinical resources that are available on the ambulance, the large majority, 87%, describe some sort of pre-transfer checklist, some sort of standardized list that they can go down and say, X, Y, and Z are all ready and in order on the ambulance before we leave. Hoping to learn a lot more about that during the qualitative interviews. And then 40% say they had some sort of clinical protocol to help make clinical decisions on the ambulance. I have more detailed data about what type of protocols those are, but for simplicity now, less than half say they had some sort of protocol to help them make decisions. Pediatric medication references, this is for like dosing, because small children and large children and adults all require very different dosages of medications, are very rare. Only one person said they've had that available. And then a phone call is in reference to the ability to contact a colleague or the referring doctor if, for example, there's a change in your patient, you're concerned, and you don't know exactly what to do. Like you need an order from a physician, for example. Only 1 in 5 said that that was available to them. And then lastly, just what resources are even available on the ambulance in the first place. I highlighted a few that I thought were interesting here. Pulse ox, which can measure the oxygen level in the blood. That was interesting to me because it seems to very rarely be used. Pain meds are generally available, and stethoscopes and blood pressure cuff roughly half the time. All right, and here's one slide that I just wanted to share. This is a bit more of a timeline for individual patients, kind of tell the story of what's been happening. I have 6 patients here. For the sake of time, I won't go through all of them. But just to orient you, on the left side is the referring hospital and what happened at the referring hospital. In the middle is what's happening on the ambulance. So the colorful circles describe the MEP's reported perception of the severity of the injury. The kind of yellowish ones are a serious injury, and the red ones are extremely serious or life-threatening. Next to this colorful grid, you can see the labels up top. First is physical exam. Was it performed? Vital signs, mental status. BEC is this WHO, basic emergency care criteria. Did they get a minimum assessment? The next is pain. And then the last one is injury mitigation. And I'll kind of talk about those a bit as we go through a few individual patients. Following that is what intervention was done on the ambulance. And then lastly, just for simplicity, at the receiving facility, I just described who received handover on this patient. So let's just start with number 3. I've got a little image of a car there. This is a patient that was in a road traffic accident, a 15-year-old. So he arrived at the outside referring hospital. At that time, he was in pretty bad condition. His GCS was 7, which is a measure of mental status, and it's severely abnormal at that point. Typically, when your GCS is that low, there are a lot of interventions that we consider doing. He got IV fluids. He did not get mannitol, hypertonic saline, some of the interventions that we often consider for like a severe head injury. And then no airway intervention, like a breathing tube was performed. Not to say necessarily they did the wrong thing. Maybe some of these weren't available to them, but just to get a landscape for what was going on. On the ambulance, again, the nurse thought his injuries were extremely serious or life-threatening. She noted that he had abnormal work of breathing, but otherwise no elements of the physical exam were performed. No vital signs or mental status were assessed. He did not have pain assessed, and he did not have, I would expect this patient typically to be in a C-collar, and he did not have one on. He did get IV fluids. When he arrived to the EMD, he was received by a doctor and a nurse. He reportedly did have a pulse at the time, but he unfortunately died very soon after arriving to the EMD. I think within about 10 minutes or so, he was unfortunately dead. So this case has really stuck with me for a while. I mean, he had very severe injuries upon arrival to the initial referring hospital. It's not to say that like his life could have been saved on the ambulance, but I do think there's a lot of room that we could have improved the care, if nothing else, more frequent assessments while on the ambulance, because he died sometime between referral and arrival, or very soon after arrival. Number 4, I've got a picture of a tree there. This is a 12-year-old who fell from a tree. She had a pelvis fracture and then a bladder and rectum injury. At the referring hospital, she was noted to have an elevated heart rate and signs of shock. A pelvic binder was placed, which is appropriate for a patient with a pelvic fracture. She got pain medication and IV fluids. The injury by the nurse who was on the ambulance was thought to be extremely serious or life-threatening. A full physical exam was performed, but no vital signs or mental status were assessed. The pain level, I've got that in yellow because it was assessed and noted to be 8 out of 10, but then it was not treated. And then as far as the injury mitigation strategies go, they did appropriately place a pelvic binder. So it's green in this case. This patient was handed over to a nurse on arrival. And then the last one that I'll do is number 5. This is a 3-year-old who had a burn. It was 40% of the surface area of his body, which is quite severe. That actually happened about a month prior. He spent several days in a hospital, a smaller hospital, went home because of the cost. Sounds like became much sicker at home and is now presenting a month later to KCMC by ambulance. So at the referring hospital, got antibiotics and IV fluid. It was thought to be a serious injury. For this patient, there was no physical exam, vital signs, or mental status performed. And again, the pain was assessed. It was 9 out of 10, but not treated. So for the best documentation that we have, it seems that this patient had severe pain, but didn't get any pain medication from initial presentation to KCMC arrival. And this patient, I believe, is actually going in for surgery soon. Does have altered mental status now at KCMC, it sounds like, and does have a blood culture that has been positive in growing bacteria. There are other cases. For the sake of time, I will skip those, but hopefully this painted a bit of a landscape for kind of what the current care looks like, especially for some of our more severe patients. All right, my last slide is just kind of some of the things that I'm thinking about in terms of the feedback that would be most helpful to me. One thing that I would really love some ideas on are how to compartmentalize all of this information into some final academic products. But I'm imagining, like I said before, to kind of have this mixed method summary timeline telling a story of what it means to care for a patient on an ambulance in northern Tanzania. Some of the mentors that I've talked to said that, too, the actual validity part that I mentioned before could be a paper in and of itself. And then third, that there will be so much qualitative information that there may be room for an additional paper there. This is actually, I've never really been through this before, so I'm hoping that others might have some input. And then as far as the validity goes, I mentioned that before. In terms of to analyze this rigorously, I've done some reading, and it looks like potentially latent class analysis may be a method to go about doing that, but I'm not very familiar with it. So I'm hoping somebody could weigh in on if that is the right way to go about it, and maybe someone who could help me figure out the actual procedures for doing that analysis. And then lastly, if you have other people in the area, connections or partnerships that maybe I haven't made yet, I think that'd be a great way to help me take some of what I've learned and turn into impact rather than just a paper in a journal somewhere. So that is what I have for today. Thank you to everybody for your attention, and any questions are more than welcome.
Great job, Matt. Great presentation. Really love hearing you talk about it. And it's kind of heartbreaking to go through it all and to see it all in front of us. Any questions from the room? So it looks like we have some in the chat. So in terms of TBI, Kelly is wondering if the WHO basic emergency care recs include neuroprotective measures, since it's elevating head of